Okay, so today what I want to go over are the cranial nerves and what cranial nerves are. Basically, cranial referring to the brain, and nerves referring to like these wire things that kind of carry information around in your body. So there are 12 cranial nerves, and they each come in pairs. So if you draw like a midline down here, everything's the same this side as it is this side. The thing with the cranial nerves is that you might initially think that because it's cranial that they're going to be central in part of the central nervous system. However, cranial nerves are peripheral nerves, which means that if there's some kind of lesion in them, it's going to be a lower motor neuron lesion. So that's just something to keep in mind as well. So like I said, there are 12 cranial nerves here, and these are just a couple of mnemonics, so we'll just go through them. So O, to touch and feel very good velvet, are heaven. Then that's just kind of a way to remember it. So first one, O, olfactory, which is here. Second one, which is optic, which is here. Third one, oculomotor. Fourth one, trochlear. Fifth one, trigeminal. Sixth, abducens. Seventh, facial. Vestibulocochlear is eighth. Glossopharyngeal is 9. 10 is vagus. 11 is accessory, and hypoglossal is 12. So that's just going down there. This second one is a mnemonic to help you remember the function of each of the cranial nerves. So some say marry money, but my brother says big brains matter more. What each of this means, so the S is for sensory, so if there's a sensory function. The M is for motor function, i.e. if you think in terms of a normal reflex arc where it's entering that way, then kind of like a interneuron, and then leaving that way. This one here will be the sensory, and this one here would be the motor, which is going to cause you to be able to do something. So S is for sensory, M is for motor, and B is for both. So kind of going through each of them now, what each of them kind of do. The way I remember as well, because these are all just 3 O's, olfactory is referring to your sense of smell. You have one nose, which is why it's first. Optic, you have 2 eyes, which is why it's second. Then oculomotor is just the third O, so it's third. Then to touch and feel very good velvet are heaven. So in terms of a general overview, so first one is smell, second one is vision. 3, 4, and 6 are all related to eye movements. You can remember that by LR6, SO4, all other 3. 5 is the trigeminal, which is here. It's the biggest cranial nerve, and it kind of does a lot of different stuff, so we'll go through it. You can kind of think of it as like muscles of mastication, so chewing, and then kind of sensory in the face. 7, facial, which is related to facial muscles. 8, which is vestibulocochlear. Vestibulocochlear is 2 words put together, so vestibular, i.e. balance, and cochlear meaning hearing, so that's related to your ears. 9 is glossopharyngeal. This is kind of in reference to your sense of like your ability to swallow and be able to produce saliva, as well as taste in the posterior 1/3 of your tongue. 10 is the vagus, which kind of does a lot of parasympathetic functions, and again, it's kind of related to the mouth, so like swallowing and things like that. 11 is the accessory, which is like shoulder movements and like being able to turn your head, so using trapezius and sternocleidomastoid. And 12 is hypoglossal, hypo meaning below, glossal meaning tongue, so it's the nerve that travels below your tongue, and it just moves your tongue around. So that's just a really quick overview. We'll go into more detail now, but before we do that, we will go over the different cranial nerves foramina. So the first one is here, which is the cribriform plate, and that's the olfactory nerve. So this is cranial nerve 1. This is for your smell. What you get is this bit here is called the cribriform plate. What it kind of looks like, if I draw something, it kind of this and this, and it's got all these holes, kind of like that. You've got this thing kind of dividing it. Oh, this is on the ethmoid bone, and what you have is this dividing bit here. It's called the crista galli. That just divides it. Ethmoid bone, the way I remember it is the cribriform plate has all these holes in. That's how you can like smell. So that's the first cranial nerve, which is the olfactory, so sense of smell. Second is the optic nerve, which goes through the optic canal. It's very straightforward. The optic nerve goes from the back of your eye straight through the optic canal and then to your brain. These first two aren't originating from the brainstem. They actually originate from the cerebrum. The rest of these, so from 3 till 12, actually come from the brainstem. So if we now actually go on to the third one, which is the oculomotor nerve, the oculomotor, trochlear, and ophthalmic and abducens, these ones all come from the superior orbital fissure, which is here. Then you have the maxillary nerve, which is a branch of the trigeminal nerve. So you'll see here, ophthalmic is V1. V1, then you've got V2, then you've got V3. V just is Roman numerals for 5. So you've got branches of the fifth cranial nerve, which is trigeminal. So then ophthalmic, maxillary, mandibular, V1, 2, and 3. And unfortunately, it's not quite in the right order, which is a little bit annoying. So you've got foramen rotunda for the maxillary nerve, which is there. Foramen ovale, which is here, which is this one. You'll see here, that kind of hole there is quite important. I'm going to do it in red, and it might give a hint of what it is. So this is foramen spinosum. And since I've done it in red, you can probably figure out that some kind of artery goes through there. The name of the artery is the middle meningeal artery. If you hit the side of your head, i.e. at the pterion region, which is the point where your skull bones fuse, and you can get like suture lines there, that's an area of weakness. If you hit that, you can rupture your middle meningeal artery and get an extradural hemorrhage, which is an arterial bleed bleeding out, and you can see that on a CT scan. So the next bit after the mandibular nerve, which is V3 and foramen ovale, is the internal acoustic meatus. Internal acoustic meatus is, so internal, inside, acoustic is like sound. You also have an external acoustic meatus, and that's basically just if you put your finger in your ear, that's your external acoustic meatus. This is now just simply on the inside. What goes through there is 7 and 8, and it kind of makes sense if you think of 8 because that's related to hearing, and then there's something about acoustic, so that's one way to help you remember it. And the next one, 9, 10, and 11 all go through the jugular foramen. Jugular foramen, you can probably imagine that the jugular vein goes through there. And then here, finally for 12, you've got the hypoglossal canal, which is where the hypoglossal nerve goes through. So hopefully they're not too bad in terms of remembering. I think normally around in the middle is where people get confused. So I just remember the order ROS. So for rotundum, ovale, and then spinosum there. And then the rest of them I think are fairly okay because all of them, the ones related to eyes are kind of superior orbital fissure. These two kind of do their own thing. And then these ones are kind of the last ones put together. And just if you have to guess for the last couple, just guess jugular foramen. So hopefully that kind of makes sense. Now we'll just go into a little bit more detail of each of the cranial nerves. So we'll start with the first one, olfactory. And like I said before, this is related to smelling. So the reason why it's the first one is because you have one nose. And this is on a cruciform plate on the ethmoid bone, and we've got crystal gallery dividing it. So if this isn't working, if you want to test someone's cranial nerve 1, their olfactory nerve, you would ask them if they have sensed any change of smell. And you could ask them, oh, okay, have you actually experienced any change of smell? You can test that through, for example, like smelling salts, or can they smell, for example, peppermint or vanilla? If that doesn't work, what you call that, their ability, if they can't smell, that's called anosmia. Something like anosmia can be used to lead to other different diagnoses. So, for example, one symptom of Parkinson's could be anosmia. So then through this, you can try figuring out and using like different clues to create your diagnosis. The next one is the optic nerve. And this is related to two eyes, which is why it's the second cranial nerve. The way I like to remember this is by a mnemonic, which is Afro-BC. You see, so A stands for acuity. Okay, so this is kind of related to how far and how near you can see stuff. So if you're testing somebody's far acuity, you'd use something like a Snellen chart. Snellen chart is one of those things that you've seen in when you go to check your eyes out. So it could be something like this, and it's like a really big letter at the top and gets smaller and smaller and smaller until you need to kind of read something like that. That's testing your far vision. You might see something in terms of when trying to figure out and comparing somebody and documenting somebody's vision, something like 6/6 versus, for example, over 6/60. What this means is it's in reference to comparing the patient's vision to what a normal patient should be seeing. So here, 6/6 is the perfect vision. At 6 meters away, the person is in comparison to somebody else who can see 6 meters away. That's great. That's normal good vision. If somebody's vision's not great, what somebody can see at 6 meters, a normal person with normal vision can see at 60 meters. So hopefully that kind of makes sense. Then the next one, and then you can also do near acuity, which is kind of just getting them to read normal text, and hopefully you should be able to get them to read the smallest print possible. Next one is visual fields. So this is just testing kind of their range that they can see around. Next one is reflexes. This is, for example, different reflexes like accommodation reflex. So that's kind of judging how far and near they can see. So if you just take your pen in front of you and then just move it back and forward, your eyes should hopefully adjust and keep the pen in focus. Next one, like pupillary light reflex, which is kind of like a swinging. So just making sure that you can have the normal response and the consensual response where your pupils can constrict to light normally. Then you have the red reflex, so that could be used for checking if somebody has retinoblastoma, for example, and you'd use an ophthalmoscope for that. So speaking of ophthalmoscopes, that would be, so this is then to check the retina, which is the back of the eye. From using this or a fundoscopy, you can use this to then check the retina. From that, you can then see the optic nerve, and it should hopefully be in the correct size. Using an ophthalmoscope, you can then check if somebody has different diseases. So for an example of this would be diabetic retinopathy. You'd be able to look at a normal one and then compare it to somebody with diabetic retinopathy, and then you can kind of see what normal should look like and then what somebody with a certain clinical disease would look like. Next one is blind spots. So this is where you'd use the red or white pin and you're just checking, for example, where somebody's blind spots are while they're still kind of looking at you. And the last one is color vision. So this is where you'd use the Ishihara plates. And then you can tell someone's got some kind of color blindness. The most common one is red-green color blindness. So if you're ever stuck, just guess red-green. So that's for the optic nerve. Then we go on to the third one, which is oculomotor. Now, I'm going to combine 3, 4, and 6 all together because they go for eye movements. So the way to remember them is LR6, SO4, all other 3. Run out of room. Yeah. So what this means is lateral rectus is abducens, superior oblique is trochlea, and then all the other eye muscles is oculomotor. So if somebody has an oculomotor nerve palsy, it would have a down and out appearance. So if I draw that would look something. If there's a normal one, it would be down, so down this way, and then out this way, which would lead it to kind of there. And that's kind of what somebody with oculomotor nerve palsy would look like. The difference between a third nerve palsy versus a trochlea or abducens is that with third nerve palsy, that can just be at rest. The other thing is you can get kind of ptosis, which is like a droopy eyelid, because the third cranial nerve also controls the eyelid, and so then that will start to droop as well. So another thing you can look out for when checking for these is diplopia, which is like double vision. The way to test each of these is by doing this movement, which is creating a H. So just asking the patient to follow either your finger or your pen, and you're just making a H movement in the air, and they just follow it, and then that will test each of the different eye muscles. So if I just write out each of them again, so this one is trochlea, and then this one is abducens. So then LR6, SO4, all other three kind of tests all of them. Somebody with a trochlear nerve palsy, this is when you'd ask them, they would have a fixed kind of upward, wouldn't really be able to look downwards, so they'd have a fixed upward gaze. And you can kind of see patients starting to tilt their head to the sides because they might struggle walking downstairs or reading. So them tilting their head to the sides trying to compensate. And the other thing with the third and fourth is that oculomotor nerve, it originates in the brainstem at the superior colliculus, while the trochlea originates from the inferior colliculus, also in the brainstem. The abducens, however, comes from the pons, and again, it's for LR6, which is the lateral rectus, so you can't, if it's not working, you can't look out. So your eye starts to drift inwards a bit. And that would look something like, that's your normal, and then something like that. Okay, the other thing about the abducens nerve, which is actually quite cool, is that in the brain you've got this thing called the cavernous sinus. Cavernous sinus is where you get venous blood draining back down to the heart. However, it's cavernous, so if I just write it out, yeah. It's got the word cave in. So the way I think of it is kind of this cave filled with venous blood. Now within there, if there's a cave, then there might be other stuff. One of those things will be the abducens nerve. So what it looks like is, think of it like that. That's your cavernous sinus. Within it, you will have the abducens nerve. And another thing you'll have in it is the internal carotid artery. So that might be like that, internal carotid artery. The other things you also have within the cavernous sinus, in the cavernous sinus on the lateral border, are cranial nerve 3, 4, and then 5, so V1 and V2. So 3, 4, V1 and 2. But that's in the lateral sinus, in the lateral wall of the cavernous sinus. And they're kind of enclosed in dura mater. The abducens nerve is fully inside the cavernous sinus. So that means within almost like a vein, kind of, you have an artery and a nerve traveling through this vein. And I think the reason is related to heat distribution. So pretty amazing. Then the next one we'll go on to is the fifth cranial nerve, which is the trigeminal. This is the biggest cranial nerve. So what you can see here, this bit here is the trigeminal ganglion. Then it splits 1, 2, and 3. The way I remember it is literally doing that exact same thing. So put your hand kind of there, and then one finger towards your eye, one towards just below your nose, and then one just to your chin. And then each of those three fingers kind of remind you of the three divisions of the trigeminal nerve. So ophthalmic, which is here, then maxillary, and then mandibular. Just below your nose, that's the maxillary bone, and then your jaw is the mandible. And ophthalmic related to eyes. So that's a nice, easy way to remember it. Then again, you can kind of get it further dividing. So if we just zoom in, ophthalmic, then that divides into more kind of nerves. So you've got frontal, then lacrimal, and nasociliary. And the mandibular can divide into buccal, inferior alveolar, auriculotemporal, and lingual. Remember, this is the lingual nerve, not the lingual branch. That will come up later on, so just remember, a branch of the mandibular nerve, which is a branch of the trigeminal, the lingual nerve. So then the next thing to remember, so that's all kind of the part from the trigeminal ganglion, and you can use this, for example, like in terms of sensing. The other thing about the trigeminal nerve to bear in mind is that there's the trigeminal sensory nuclei. So that kind of divides into three things again. So there's three of them. So the mesencephalic, chief or principal, and spinal. And each of these are the trigeminal nuclei. So what each of them do, mesencephalic, you can kind of test it with jaw jerk. What it does is it prevents you from biting down too hard and almost like shattering your teeth, like losing teeth. So don't bite too hard. Chief nucleus is for discriminative touch, light touch, and kind of proprioception of the jaw. So discriminative touch, light touch, proprioception of the jaw. And then the spinal nuclei is for kind of the opposite of the chief nuclei, which is crude touch, pain, and temperature. Okay. So those are the three different kind of trigeminal sensory nuclei. The other thing to kind of think about with the trigeminal nerve is, I said that think of it with chewing. So it does muscles of mastication. What are they? So there's the medial and lateral pterygoids. So masseter and temporalis. So as you can probably imagine, so pterygoids sounds a bit like pterodactyl, meaning wings. So that's kind of around like this level. And then temporalis, think of it as your temples. There's a muscle here. When you clench your jaw, you can actually feel your temporalis contracting. That's one of the tests for the trigeminal nerve. So ask someone to tense their jaw or feeling for the like on their temporalis and their jaw, and you can actually feel it working. Another thing that the trigeminal nerve does is the tensor tympani muscle. So this is in your ear. It basically dampens the sound, so really, really loud sounds don't damage your ear. So I'll just write that. This. Yeah. So the way to kind of test the trigeminal nerve is touching kind of V1, 2, and 3. You can test it the sensory with like a cotton wool and just see if they can feel it. And then kind of get them to clench their jaw. That all works. If somebody has a trigeminal nerve lesion, I remember that would be a lower motor neuron lesion because a peripheral nerve. They could get something like trigeminal neuralgia, which is, you can also, if someone gets brain freeze, say from eating too much ice cream, what you're feeling is kind of pain in the trigeminal nerve. One of the other things that will be affected if there's a problem with the trigeminal nerve is the corneal reflex. So the afferent branch of the corneal reflex is controlled by the trigeminal nerve. The efferent is the facial nerve. Another thing that will be affected is your face sensation is going to be affected. Again, you can probably figure out that chewing is going to be affected, and then your jaw will also deviate to the side of the lesion if there is some kind of trigeminal problem. So we've already done abducens, so we've done 6, now let's go into 7. So with 7, this is now the facial nerve. As you can probably imagine, this is something to do with the face, and that's exactly what it does. It controls the facial muscles, so it controls facial expression. So whether you're looking happy, sad, worried, or irritated, or confused, this is all done by the facial nerve, which controls your facial muscles. Also, there's a sensory component to it, which is the external ear. So parts of the ear that you touch you'll be feeling that via the facial nerve. Other parts you'll be feeling via the vagus nerve. So sometimes people say that if you put your finger in your ear, you might feel like you might cough, and that's related to then your vagus nerve. So what the facial nerve does, I've kind of got a thing here. You've got facial nerve and then divides into different branches, which are here, and temporal, zygomatic, buccal, mandibular, and cervical. There is a little acronym to remember it. So to Zanzibar by motorcar. And then, like I said, you can do with the trigeminal nerve, where you put your fingers kind of in the correct locations to help you remember it. You can do the same with facial nerve. And that's kind of the different course that those nerves run along. So one of the other things to bear in mind with the facial nerve is the tongue. So with the tongue, you have the anterior 2/3 of the tongue controls taste. And so I'll write that with this. And that's via the cauda tympani nerve. So the other thing to remember with the facial nerve is that there is the parasympathetic aspect of it, where it controls different glands. So you have the submandibular, sublingual, the nasal, palatine, and lacrimal gland. So the lacrimal gland is controlled by the greater petrosal nerve. Oh, and the area that's kind of confusing is with the facial nerve, you have anterior 2/3 is controlled by two nerves. So the taste is controlled by the facial nerve. However, in terms of general sensation, that is controlled by the trigeminal nerve, so the mandibular branch of the trigeminal nerve, so V3. So there is a difference between general sensation and taste. So I guess if you just kind of like your teeth touch your tongue, that would be via the trigeminal mandibular branch. However, if you're eating and then you're tasting food, that's via facial nerve. So the next thing to bear in mind with the facial nerve is you have the stapedius reflex. This again is kind of similar to tensor tympani. What this does, it attaches to the stapes bone and it kind of pulls on it when there's going to be a really loud sound, so it just protects the ear. If there is some kind of cranial nerve 7 palsy, what happens is this won't work, and then you might get hyperacusis where things sound louder than they actually are. So speaking of cranial nerve 7 lesions, what this is called is Bell's palsy. This is one thing to really learn. Here's actually a picture of Bell's palsy. So this one is Bell's palsy. What's going on here? You could literally draw a midline down, and all of this side is affected. The reason why I put it compared it next to someone with stroke, is that this is something that people then get mixed up. Because they can present somewhat in similar ways, where like one side of the face looks like it's starting to droop a bit, Bell's palsy can get misdiagnosed as stroke or vice versa. The way to remember is looking at the forehead. So you'll see the difference here, all of these wrinkle lines on both sides versus wrinkle lines here and nothing there. So what's happening with Bell's palsy? Cranial nerves are ipsilateral control. So what happens is this entire side is then affected and none of the facial muscles on that side are working. However, in terms of a stroke, only this side of the face is going to be affected. This can still work. So that's where you can look at if it's a forehead sparing kind of paralysis. So what is Bell's palsy? So lesion of cranial nerve 7. And you can get, if you just go through each of the different components of facial nerve, so their facial expression is going to be affected, their taste will be affected, things might sound louder than they actually are, but hopefully it's not too serious, so you can just get it treated, I think with a course of steroids. So then moving on to the 8th nerve, which is the vestibular cochlea. This, like I said before, splits into two words, vestibular and cochlear. Vestibular meaning balance and cochlear meaning hearing. So when you look at a diagram of the inner ear, there are kind of two components. There's the cochlea, which is how you're actually hearing like sound, and then that goes then on to the brain to actually understand and make sense of what these sounds that you've heard. And then you've got balance, so you just don't fall over every time you stand up, for example. That happens at the semicircular canals. These two nerves combine to form the vestibular cochlear nerve, and then that goes on from there. A way you can test this is through with a tuning fork, so Weber and Renee's test. So here's a person. You can do Renee's test, which is, there's your tuning fork. You kind of hit it on with the side of with your hand. It then vibrates, and then you put it just next to someone's ear like that, and then they're just hearing it via the air. And then the next part of that you can do is putting it kind of on their mastoid process, so then it's actually on the bone, and then they're hearing it via bone conduction. And then from there you can try working out whether or not there's whether sound is amplified via bone or via air, and you can work out where kind of problems are on where it's external or middle ear or just the internal ear where there's a problem. So that's Renee's. The way I remember it is because like the tuning fork's near to the ear and ear kind of ringing sound, so Renee's ringing. And then here's another person, and this is Weber's or Weber's, I don't know how to pronounce it. Then you just put the tuning fork on their head like that, and it's vibrating. And from that, it's via bone conduction now, you can tell whether the sound is lateralized to one ear, whether it's equal, and from that you can then work out what kind of hearing deficit there is. The way I remember this is you've got ears kind of like that, and then it kind of, if you put this tuning fork in the middle, 1, 2, 3, form a W like Weber's. So if there's a problem with the vestibular or with the vestibular cochlear nerve, you can get something like vertigo, you can get nystagmus, you get just general nausea, vomiting, and you can just get loss of balance. There is a tumor of the cochlear nerve which is called an acoustic neuroma or an acoustic schwannoma, and then that will lead to kind of similar problems like that. You can then again do Renee or Weber's test. Okay, going on to the 9th cranial nerve. This is the glossopharyngeal. So, the glossopharyngeal nerve, this kind of controls things like salivation and swallowing. So, cranial nerves like 9 and 10, when you're testing them, it's kind of going to be testing around the mouth. So, salivation and swallowing, things like that. So, what you can get is the posterior 1/3 of the tongue is controlled by the glossopharyngeal nerve. So this is now like taste. So taste of like the posterior 1/3 of the tongue. So remember the anterior 2/3 were controlled by the mandibular division of the trigeminal nerve, which is general sensation. And then the next one is for taste, which is facial nerve. So with the glossopharyngeal, let's just put down posterior 1/3 of tongue for taste. There's also the parasympathetic control of the parotid gland. So if we go back to the facial nerve, these kind of divide. You've got one facial nerve going that just divides, and it divides at the level of the parotid gland. Parotid gland's kind of behind your ear. And then from there it then divides, but however the glossopharyngeal nerve actually controls the parotid gland. And that's what causes salivation. Another thing you'll probably remember from first year with the glossopharyngeal nerve, something related to the heart, and that's the carotid sinus nerve. So that controls like the baroreceptor reflex, so controlling like blood pressure and oxygen saturation. You then have, when I said with the mandibular branch of the trigeminal nerve, there's the lingual nerve. Here's why I said it's the lingual nerve and not the lingual branch. The glossopharyngeal nerve has some divisions where it goes, for example, so pharyngeal branch, lingual branch, and tonsillar branch. So this is now a branch, not a nerve. The lingual nerve is off the trigeminal nerve, which is like the V3. So if there's a lesion in the glossopharyngeal, what you'll see is you'll get a hypersensitivity of the carotid sinus reflex. And so then kind of your blood pressure might be a bit messed up. And the other thing is the gag reflex. So if, for example, someone puts something in your mouth and you're starting to swallow it and you just don't like it, you'll have a gag reflex. The afferent arm of that reflex is the glossopharyngeal. The efferent is the vagus. So if there's some kind of problem with glossopharyngeal, you're not going to have a gag reflex because you don't have an afferent limb for that. So then speaking of the efferent limb of the gag reflex, that would be the vagus nerve. So that's cranial nerve 10. Vagus is the longest nerve out of the cranial nerves, and it kind of just goes down the neck and then kind of into the thorax and abdomen. Vagus means like wandering nerve. So and the other thing about the vagus nerve that you'll probably remember from first year, again, it kind of does stuff with the heart, and it kind of the aortic arch. It also has a very like big parasympathetic role in different organs. So it can like slow down the heart rate, control like digestion. The thing with the vagus nerve is there's also a point of asymmetry where the left recurrent laryngeal will loop under the arch of the aorta compared to the right side, and that's an area of asymmetry. So the vagus nerve, again, in terms of testing, you kind of combine it with cranial nerve 9, glossopharyngeal. One of the things I said before was like with facial nerve, when you're feeling like your external ear, part of that is controlled by the vagus nerve. So the auricular branch of the vagus nerve is for sensation of the external ear. It also controls a lot of kind of throat and mouth stuff. So one of the things is like the larynx. So let's write larynx. Larynx ends with an X, and the way I remember it is like X and 10, or like via Roman numerals. And so the larynx is kind of controlled by the vagus. And the other thing I remember for the larynx is scar. So superior laryngeal nerve is for cricothyroid. All others are recurrent laryngeal nerve. So that's kind of in terms of the muscles for the larynx. What this kind of looks like is, if here's your vagus coming down, it will kind of branch off there. There's your recurrent laryngeal, so you're going to call it RL. And then you've got the superior laryngeal nerve, which comes off above, like that. And then it splits into internal and external. And that's kind of how you get a branching pattern in the vagus nerve. So yeah, vagus nerve kind of controls the majority of muscles with the pharynx and larynx. But again, it's one of those things where you'll sometimes get a bit of cranial nerve like 9 controlling it. So kind of just got to go with it. So swallowing and phonation are controlled by vagus nerve, roughly. And if you've got a hoarse voice, there's some kind of problem with the recurrent laryngeal nerve. If there is a lesion of the vagus nerve, you can test that by asking someone to open their mouth, and their uvula will deviate to the side, will deviate away from the side of the lesion. So the uvula is that dangly bit at the back of your throat. Uvula comes from like Latin or Greek or something, and it means bunch of grapes. So I guess it kind of looks like it. And so uvula away. So if you've got a lesion of your right vagus nerve, uvula will deviate to the left. And then the other thing, again, like glossopharyngeal, gag reflex is going to be affected. Okay, and going on to now cranial nerve 11, which is the accessory nerve. The way to test this is this is all about head movement. So this is kind of, if you're like nodding or like shaking your head or shrugging your shoulders. So those kind of head movements related to the sternocleidomastoid. And then trapezius, which is on your back, that is for shrugging your shoulders. So if you want to ask someone, if you're going to test someone's accessory nerve, just ask them to shrug their shoulders. And that's basically everything with the accessory nerve. It's quite rare to get a lesion of the accessory nerve. You can maybe get some kind of other problems related to it. But yeah. Then kind of going on to, okay, so yeah, you've got sterno. So head and shoulders. Yeah. And then you've got the final one, which is hypoglossal. Hypo meaning below, like I said before, and glossal meaning tongue. So 12th cranial nerve controls your tongue. And it basically controls the majority of your external and extrinsic and intrinsic tongue muscles. So if you have a lesion of your hypoglossal nerve, your tongue will deviate to the side of the lesion. So the other thing to think about with the hypoglossal nerve is this thing called the Ansa cervicalis. So it's not related directly to cranial nerves, but I'll just kind of give a brief word because it can be a little bit confusing. So I'll do it here. So this isn't a cranial nerve. However, yeah, it can be a little bit confusing. So Ansa cervicalis kind of means like handle of the neck, and it's just kind of a loop off a nerve. If you've got kind of it comes from C1 to C4, C4, and what it looks like is, if this is then your cranial nerve 12, hypoglossal. You then have C1, 2, 3, and 4. You have kind of a superior branch and a superior and inferior roots, which then lead, and then the actual loop is the Ansa Cervicalis. So here, this kind of goes like that, and it kind of goes alongside with hypoglossal, and then starts there. That's then the superior root. Then you've got kind of these inferior roots, which is for C2 and C3, kind of joined together. And then the actual kind of loop, which is kind of like that bit here, is the Ansa Cervicalis. So that's the kind of bending bit. And Ansa Cervicalis just kind of supplies some of the infrahyoid muscles, which infra meaning below, hyoid is a bone that's not attached to any of the bones, and you can kind of feel it in your throat, and it just brings it down. So yeah, hopefully that explains all of the cranial nerves.